Hello dear students, welcome back to my YouTube channel Physiology Learning. Today we are continuing with the ECG series. In the previous video, we have discussed about the Wolff-Parkinson-White syndrome. In this video, we are going to discuss another clinically important disease that is related to the cardiovascular system, and it can be easily identified in an ECG, that is the heart blocks. It is also called as conduction blocks. So we will be understanding what are the different types of it and what are the classical ECG findings in this heart blocks. So first, coming to the conduction blocks, it is generally divided into three different types. 1, 2, 3. Obviously, it's easier to remember. It's first degree heart block, it is second degree heart block, and third degree heart block. So what we will do is we will discuss the first and third, then we will go on to the second. I'll tell you why, because it's easier to understand in that way. So first, coming to the conduction system, all of you know that the firing starts from SA node, which is the pacemaker or the dominant pacemaker. Then it reaches the AV node, which is also called as the gatekeeper. Then after that, it comes to the bundle, then right and left bundle branches, then finally the Purkinje fibers. So when it is traveling in this pathway, AV node is one region where it is generally stopping the impulse and sending it to the ventricles. If there is any problem in the AV node, then it will create the conduction blocks. So this is the area of the interest today, like the AV node. So AV nodal delay, what does it segment which it can be read in the ECG? All of you know that is the P wave, then QRS complex and the T wave. This PR segment is because of AV nodal delay. So now this conduction block also will be dependent on this interval only and what happens to this interval. And there are some other types where the complete block is also there. So coming to the first degree heart block, I would say that this is actually a misnomer. Why? Because here it is not getting blocked. To be true, it is not getting blocked. What is happening is the PR interval, that is a P wave, along with the PR segment, it is getting prolonged. The duration of PR segment is prolonged, so obviously the PR interval duration is also prolonged. As you can see here, it is getting prolonged. So what is the normal duration? Normal duration I have already told you in previous video. The normal duration is 4 boxes. Up to 4 boxes it can be considered normal. Less than 4 boxes is usually considered as normal. So it is nothing but 0.16 seconds. Whenever the PR interval goes beyond 5 boxes, then we can call it as a first degree heart block. So whenever it goes beyond 0.20 seconds, we can call it as first degree heart block. How I am saying this calculations of 4 boxes, 0.16 and all, I have already dealt in the basic videos. Kindly do watch that and come back to this video. So if it is more than 5 boxes, then it is called PR interval prolongation, which is also called as first degree heart block. Ideally, if you think here, is it stopping the impulse from going from SA node to the ventricle? No. Here the AV node is prolonging it, but again you will have a proper rhythm. So as you can see here, every P wave is followed by a QRS complex. The P wave is followed by a QRS complex. There will not be any kind of impulse that is being stopped. So that is the first degree heart block. Now coming to the third degree heart block. It is very simple. Third degree heart block. The SA node is there, then the AV node is there. This is the SA node, then the AV node. All the impulses of SA node are blocked by the AV node. It is not conducting even a single impulse from SA node to AV node. Then what will happen to the ventricular contraction? The person will not have ventricular contraction for a certain amount of time. So what will happen to him? He will become unconsciousness and he will faint. Why? Because the impulse from the AV node is not being connected to the ventricle. So obviously heart is not pumping, the blood supply to the brain is compromised, he will become unconsciousness. And this syndrome is called as Stokes-Adam syndrome. This you must have read before also. But will the patient die? Sometimes they might die also. But sometimes what happens is, I have already told you the pacemaker cells are present in the ventricular fibers or the Purkinje fibers also. So what will happen is, after some time, initially the SA node is a dominant pacemaker, but after some time they will start firing and help in depolarizing the ventricle. So how will be their ECG? Their ECG will be, the atria will be beating on its own, the ventricle will be beating on its own. There will be no conduction between the atria and ventricle via the AV node. So the P wave will be coming on its own will, the ventricle will be coming on its own will. Only new thing is, if you remember, the ventricular potential to generate its own impulse is very, very less. So it will be beating around, let's say, 20 to 40 beats per minute. Whereas the atria will be beating at a normal impulse, that is 60 to 90 or around 70 beats per minute. Will there be any pattern? No. The P waves will be keeping on coming. In between that, you will be finding a QRS complex. So as you can see here, now we have 3 P waves followed by a QRS complex. Then we have 1 P wave, 1 QRS complex, 1 P wave, 1 QRS complex. Then there are multiple P waves coming in. Then there is 1 QRS complex. So is there any pattern? There is no pattern. Here the atria is beating on its own, the ventricle is beating on its own. Then how will you calculate the heart rate of this individual? The heart rate of this individual will be calculated for both the atria and ventricle separately. So the atrial heart rate will be calculated using the PP interval. So that will be the atrial heart rate. And the QRS complex duration or the RR interval will be used to calculate the ventricular heart rate. So here you can see that the same person is having a separate atrial heart rate and a ventricular heart rate. So in first degree, what did we saw? In first degree, there is just a prolongation, but all the SA node impulses are being conducted to the ventricle. In case of third degree, all of them are blocked. None of them is coming. So the atria is beating on its own, the ventricle is beating on its own. Now the second degree block is somewhere in between these two. In the second degree block itself, there are 2 divisions. That is Mobitz type 1, Mobitz type 1 and Mobitz type 2. So there are 2 different types in the second degree block itself. Here what happens is, in Mobitz type 1, it is also called as Wenckebach phenomena. What happens if you closely observe, there is a PR interval. So this is the PR interval, then this is the next PR interval, and next there is a P wave and we do not have a QRS complex. So what has happened in this person, if you closely observe, the PR interval kept on prolonging until a QRS complex is dropped. It is a very classical pattern. Here what happens, initially the AV node, its impulse is coming, it is delaying a bit. Now second impulse is coming, it is delaying a little more. The third impulse is coming, it is delaying still more. Fourth impulse is coming, it is not sending at all. So in this pattern, it is a very classical pattern of Wenckebach phenomena where the PR interval keeps on prolonging until a QRS complex is dropped. The QRS complex is dropped. This type of classical pattern is called as Mobitz type 1. Now coming to Mobitz type 2, here what is happening? Here P wave, QRS complex. P wave, QRS complex. P wave, QRS complex. Here there is a certain pattern. As you can see here, there are 2 P waves followed by 1 QRS complex. This is also called as 2:1 block. For every 2 P wave, only 1 is being sent into the ventricle. So this is a classical picture, 2:1. And in the second, we can see all the P wave. So 3 P waves are there followed by a QRS complex. So that is 3:1 ratio. So this type of classical ratios are seen in Mobitz type 2. Let's recap a bit. So what you have to do is, first thing is you should observe the PR interval and observe whether the P wave is followed by a QRS complex. So whenever you are checking the rhythm strip, and you are able to spot that every P wave is followed by a QRS complex, that is the rhythm analysis. And if the PR interval is kept on prolonging with no other abnormality, no other dropping of QRS, it is type 1. Whereas in first, that is first degree. In third degree, all the impulses of the atria are not conducted to the ventricle. The atria is beating on its own and the ventricle is beating on its own. Whereas in type 2, we have further 2 more divisions, Mobitz type 1, where the PR interval keeps on prolonging until the QRS complex is dropped. Here there are certain patterns like 2:1, 3:1 type of, that is 2 P wave followed by 1 QRS complex. So these heart blocks are easier to spot in the ECG because once you analyze the rhythm strip and you are able to spot the P wave and the QRS complex sequence, you can easily identify the heart blocks. So I hope it's clear. Thank you for watching the video. If you have any further doubts, kindly drop it in the comment section. I'll be happy to make a video on it. Thank you for watching. We'll stay tuned for more such videos.